Hi, welcome to this webinar about outbreak management planning from the Aged Care Quality and Safety Commission. My name is Nicola Dunbar. I'm the National Manager of Organisational Development at the Commission, and I'm going to be facilitating today. Before we begin, I would first like to begin by acknowledging the traditional owners of the lands on which we all meet in our various places in Australia and pay my respects to elders past and present. What we're going to be doing today is looking at a new resource that's been released recently by the Commission, Outbreak Management Planning in Aged Care. The purpose of this session is to provide some information to help familiarise you with that resource. We're not going to be kind of walking through the resource step by step, but really drawing on our experiences at the Commission since March with COVID, both from specific services and also for the sector as a whole. And we'll be drawing on that to provide you with some kind of key information and things to take away, but also to take you through the prompt around the resource and how you can use it in your service. We'll have three speakers today. Commissioner Janet Anderson will be speaking about the resource, what it means, why it's useful, and the kind of overall approach about how you need to use it in our COVID normal world going forward. Janet will be followed by Melanie Roth, our Chief Clinical Advisor, who will be speaking particularly from a clinical perspective about things that have gone wrong, what we can learn from that, the importance of planning and prevention. And the final speaker will be Anne Wunsch, our Executive Director of Approvals, Compliance and Investigation, who will be really focusing on lessons learned around COVID from her time, particularly with the Victorian Aged Care Response Centre down in Melbourne with the Victorian outbreaks. We'll have about 10 minutes each for each of the speakers, and then we'll have about 15 to 20 minutes of questions. So you can start to put questions in any time, and we will be going through those at the end. We probably won't be able to go through all of the questions, but please put them all in and we'll be able to draw that together to provide information back to you. So at this point, I'll stop, hand over to Janet to introduce us to the session.
Thanks, Nicola. Good afternoon, everyone. It is great that you can join us this afternoon for the webinar to discuss our guide on outbreak management planning for residential aged care. I want to make a few introductory comments, as Nicola said, and then hand over to my colleagues who will deal with the greater detail. As the national regulator of aged care, the Commission has approached the topic of outbreak management planning through the prism of the quality standards, and you'd be unsurprised by that. As you all know, the Aged Care Quality Standards outline a set of community expectations framed within the Aged Care Act in relation to the safety and quality of care and how that care contributes to the well-being and quality of life of aged care consumers. And of course, all providers are expected to comply with the standards. There are a range of requirements under the standards which are relevant to a discussion about the sector's response to the COVID-19 pandemic. Just to mention a few, there are requirements in relation to infection prevention and control, risk management systems with a special focus on managing and mitigating high-impact risks, the need for a clinical governance framework, ongoing engagement with consumers and their representatives, and that's just a subset of potentially relevant standards. So under the Act, every single provider has a legal obligation to fulfil or satisfactorily address these requirements at all times. And there's no footnote in the Act which says except in a pandemic. So over the course of the pandemic, the Commission has had and has made good use of an unparalleled opportunity to gather intelligence about particular providers and about the sector as a whole. And what we already knew and have had confirmed over the last 9 months is that the aged care sector is characterised by diversity in size, scale, complexity, needs of consumers, staffing profile, and indeed provider capability. And let me just pause on the last of those, provider capability. We have seen providers who have been drilling their outbreak management plan in February. We have seen other providers who are still reminding themselves what PPE stands for in May, and all points in between. Well, we at the Commission are determined that no provider will be left behind, because all Australians expect that the sector as a whole and every provider in the sector is on top of your game in response to the very real risks that the COVID-19 pandemic continues to present. And our guidance is aimed at assisting you in that work. Now, there have been a number of publications which have been released by a range of different players over recent months, and we're not seeking to duplicate that effort, but rather draw from that and synthesize it into very practical, action-oriented guidance. And that's exactly what our document does. It converts theory into practice for you. And if I can give you a user's guide, you would be familiar, or some of you at least would know, the plan, do, check, act cycle. Well, this is a version of that. What we're asking you to do is to plan, set in place certain arrangements, drill those arrangements, and then on the basis of the experience of the drilling, adjust or improve. Plan, do, check, act. Plan, set, drill, improve. It's the same sort of cycle. Now, a few guides to the document itself briefly. You'll notice that each chapter has 3 main sections: an at all times section, a section in areas with community transmission, and a third section in the event of an outbreak. Those are obviously geared to ensure that you are adapting to local circumstances and the presence of virus in local communities. And it reflects also the recently released advice with AHPPC endorsement in relation to escalation and de-escalation tiers. The majority of the guidance refers to what you should be doing now in the absence of local community transmission. And we'll be underscoring that in the presentation from here on. Now, another navigational aid to the document is the breakout boxes. There are a number of them which are shaded in the document, which you will see if you even glance between the covers. There's important note, which is tips. There are key messages which appear at the beginning of every chapter, provider responsibilities which have direct regards to the relevant requirements under the standards, test your outbreak management plan, which that section poses questions that should be able to be addressed by reference to your outbreak management plan, and then consider who is responsible for. Every task must have an identified owner, and this cannot be left to chance. And then there are key takeouts from the text. That's about as much as I want to say by way of introductory comment. I'll hand back to Nicola, who will then steer us through the further discussion into the more detailed elements of the outbreak management planning guidance. Thanks, Nicola.
Thanks, Janet. And before I hand to Melanie, we've had a question already about whether or not the webinar is being recorded, and it is. It will be available on our website within a week or so, and so you'll be able to use it within your service as well. So just to let you know that it is being recorded. So I'll hand over to Melanie now.
Thanks. Hello. This guide has really been developed in response to the learnings that Commission staff have had when we've been attending literally hundreds of meetings in relation to individual outbreaks in 4 states. And it became very quickly apparent to us how very different was the readiness of different providers, and how not all services were as ready as they genuinely thought they were. So we've been able to identify gaps in responses and themes of gaps as well. And it's important to know that what people think is going to happen is not always what happens. So it's important to really think creatively about what might happen that you haven't already thought of, and I'll go through some examples of that. And also what people know in theory is very different when it's required to be put into practice, particularly if they've never put it into practice before. Things that require physical drills in an ongoing manner, not just once 6 months ago, need to be kept updated. And any plan that takes a set and forget approach is not really going to work when things need to be actively updated in a number of ways. So it's apparent that even services with very good plans that are very well thought out, that sometimes the circumstances of the outbreak is outside the scope of this planning. So thinking through in each component, when you look at the guide and check your own plan against it where it's relevant, look at each of those points and scenario test what could possibly happen. And what's the worst case scenario is not a bad question to ask, because we've certainly seen instances where the very worst case scenario was pretty much the opening event. So every component of the readiness needs to be tested along the sort of lines of, if this staff member who's got a key role, if this staff member is the index case, what does that mean for the service? What's plan B? If the outbreak is in this particular wing of the service, what does that mean for the cohorting arrangement? What does it mean for how many staff have worked there? If you've got a higher rising level of community transmission, how do you manage the risks for the service and those individuals? And I'm not talking only about the risk of the virus, I'm talking about the other risks, the clinical risks that consumers already have, and the clinical risks that consumers develop very quickly in a situation where there's restricted access and egress, and where there's also restricted visiting and restricted activities. So knowing in advance who you're going to get to help you manage those risks is something that is well worth looking at. So the plan needs to have detailed consideration of your individual service. Where providers have a number of services and the outbreak plan is the same for each service, that's not going to work for most of those services. They've absolutely got to be individualised and updated. So training and knowledge of every person's role and confidence, you as a provider having confidence that every person knows exactly how to do it is absolutely crucial. So when an outbreak begins, and the people who happen to be there at the time, depending on what time of day and what shift the outbreak is declared or recognised, that where people on the ground at the time did not know what to do, that led to a degree of panic, disorganisation. People would either leave in fear, or they would omit things that were crucial, or there would be delays. And delays in implementing a plan in an outbreak setting are risk. And I'll go into that later. But where people know exactly what to do in a military style model, they get on and do it, and you'll find that everything is much more likely to work like clockwork. So where people on the ground at the time didn't know what to do, didn't know where things are, didn't know who to talk to or who to notify, and what the immediate risks and priorities for their action was, that's when things start to go pear-shaped in a way that becomes then very difficult to retrieve. So it's really important to look at every detail in relation to your own individual situation and scenario test your service for each step of the process. Who will do each step? Are they trained for it? Who will do it if they can't do it? And this needs to be done for each shift, for each location within the service, for each key person, every time there's a new staff member, and at each point in time if you are finding yourself escalating through the tiers. So I'll give you some examples of things where better planning would have led to different outcomes. So where somebody is trying to ring the service to tell them that there's a positive test, it may be a staff member who's been notified, or it may be a public health unit trying to get hold of you at 6 or 7 o'clock at night, and where the phone isn't answered, or where the person on the ground isn't the during normal hours key person, and they actually don't know where the outbreak management plan is, who's the person they're meant to notify, what the process is from there. If the person who's the index case, so the person, let's say it's a staff member who works in a particular area which had not been scenario tested, and we had an example of where the outbreak was initially identified in the kitchen had to be shut down immediately, and then there was a panic situation really of where are the residents going to get their next meal from. And in fact, that's an issue that when you think about it can often be solved relatively easily, but not when you're in a panic situation or a crisis situation. We had services that had, knew exactly where all their PPE was going to be disposed of, and they'd identified the position within the service, and they just failed to understand what enormous volumes of rubbish there would be, and that they actually needed skips, not bins. And to have increased collection, we had services that had identified a nice storeroom to store PPE and had absolutely no idea that it was going to arrive by the pallet load. They had residents who hadn't been prepared in any way for an outbreak and had had inadequate communication when the outbreak started, who didn't know what was going on. They were fearful, they were coming out of their rooms, they were wandering around, they were trying to contact their relatives, and you can see how that not only impacted on their well-being but also impacted on the infection prevention control. And we had services where there was an assumption that every GP would continue to look after their own patients in the normal way, and for many different reasons GPs were not available to come to the service and do that. So those are just a few examples. I'm sure you could look at your own service and see areas where strange things could happen that you haven't thought about, and it's really an opportunity for many people to identify areas that, or things that could possibly go wrong. What could possibly go wrong is a really good question to ask. So I want to talk a bit about delays and why they're such a risk. I mean, that's probably obvious that if there's a delay in getting everyone into PPE, or a delay in realising that you've got an outbreak and starting to lock down and get the thing in process, every hour of delay is where people who are infected or potentially infected are touching surfaces and wandering amongst each other and potentially greatly increasing the outbreak before you even realise you've got one. So delays can be in detection, which goes to your screening, your monitoring of residents, the ability of your staff to understand that residents may present with atypical symptoms. Delays in implementing the test, so you need to get people tested as quickly as possible. You need to have the results being able to be notified as quickly as possible, and you need to know who's looking at those and what to do with them, and who they're notifying when they get results. Delays in contacting staff if the details aren't up to date, if you don't really know what people actually worked rather than what they were rostered, where they worked in the service, what their current contact details are. If you're planning to cohort the people who are going to be looking at where the outbreak is and how you're going to adapt your cohorting to your individual situation, you really need to have a floor plan available. So that needs to be available rather than trying to be found or hand-drawn, and really not being available for another 3 days. You need to have the isolation and PPE use initiated immediately, and you can quite clearly see why any delay in that is a risk. In advance, you need to look at your own cohort of residents, particularly in relation to their individual clinical risks, and obviously that needs to be reassessed every time you get either a new resident or a new clinical issue. But I wanted to talk briefly about people with dementia, where their management in an outbreak setting may be more challenging, and identifying, for example, areas where people are familiar with wandering and where they can continue to wander safely, and how you're going to block those off or factor that in. And I can give you another example of where the area that was identified for residents, or a particular resident to wander, also was the area identified for storing the pallets of PPE. And those two didn't mix very well, so there had to be a rethink of that fairly quickly. But if people are if you can anticipate difficulties in managing people when you're trying to keep them in their rooms and they can't understand it, and that's not their normal behaviour, then you need to have try and get an idea in advance of how you're going to manage that. Get advice in advance if you can, and have an idea of what staff you're going to need and how you're going to look at those particular risks. So the risks of putting people in any sort of lockdown or disrupted setting in terms of physical deconditioning, psychosocial declines and nutritional issues, it's very quick for those things to become a big problem, and they need to be looked at proactively. It's not really ideal to be finding out that a lot of your residents have lost 3 or 4 or 8 kilos and then trying to catch up when there are things you can do in advance to try and prevent those things. Another thing is really to identify who is crucial to your service in advance, so who are really important visitors for individual residents, how you can manage that maybe in a partnership type way, and which allied health or which other professionals are prepared to come in and can do things remotely or are still going to be able to know the residents and still consult in some way. Another area of lack of forethought was when a large number of staff are furloughed and are off, and then there's a perception that you just don't have enough staff to deliver care, when the staff who are furloughed actually can do a lot, and you can do a lot in advance to work out what sort of roles they can have with managing logistics and ordering and communications, clinical oversight, taking handovers, and maybe being responsible for overseeing the care of individual residents that are at high risk. Just want to really briefly touch about how outbreak readiness and how the component of really understanding the basics and doing the basics and overseeing the basics is what is probably going to be your best friend here, both in terms of developing a long-standing culture but in risk reduction. So if you happen to be the service that's unluckiest enough to be the first service of an outbreak when there really wasn't any known community transmission, is it going to take hold? Is that virus, when it comes in, going to take hold in your service? And if you can imagine somebody coming in, they genuinely are asymptomatic, they come in, their temperature's okay, they touch their face, they touch a service. You've got virus in your service there, nobody knows it. And if the basics are done, is that going to stop that virus going anywhere? Are you going to be an outbreak that never happened and you're never going to know that you were a near miss, but it's because everybody adhered to the basics? So is that person washing their hands before they touch? Are the surfaces adequately cleaned? Is the next person who touch it going to sanitise their hands, or are they going to be touching their face or caring for a resident? And checking that people are really adhering to the 5 moments and proper thoughtful getting into habits of doing these things religiously, I think you'll find that you'll be able to have greater confidence that you're either having virus coming into the service and it's going in a very localised, contained place, or you're never even going to know you had it, which is obviously the ideal. And we know where there are very large outbreaks, services with very large outbreaks, but we don't know the services that were able to avoid it, not because of good luck, but because of good management. And that's really where you want to be. And another message, other than the touching message, I think, is if you see people close together, you might just think, if one of those people is positive tomorrow, how close do I want those people to be today? And those sort of things, they're easy messages to give, and it needs to be given to all staff. It's no good having the clinical staff really good, but all the other staff in the service not being really good. You're still going to get the transmission. So that's really all I wanted to say, Nicola. But I think just go through the detail. The devil's in the detail.
Fantastic. Thanks, Mel. We've got quite a few questions coming through, which is excellent. Please keep sending them through. We'll have time after the speakers to go through them. So we've got great questions to start with. Please keep sending your questions through. So I'm going to hand over to Anne now, who will speak particularly about her experience at VARC.
Thanks, Nicola. So I want to provide some context that significantly informed the development of this guidance document. In late July, I was deployed to the Victorian Aged Care Response Centre, and there I joined other Commonwealth and Victorian state colleagues, a number of agencies to respond to the Victorian outbreaks. I led the prevention cell, which was made up of a number of medical officers, geriatrician, infectious diseases specialists, infection prevention control consultants, and also a team of ADF members. Now, our work predominantly was to work with services that were outside the outbreak zone. So they were services that we were seeking to engage with to understand their outbreak preparedness and readiness. And we conducted visits to provide training and also to make observations of the practices, the infection prevention control practices at these services. Now, in the evenings, we had a different task, and we held Zoom meetings with staff that were from outbreak sites, active outbreak sites that were at home. Some of them were quite sick with COVID, others were quarantining, and some were staff that were joining us from the aged care service to understand how to work safely in the COVID space. So we spoke with those people. We spoke to numbers of them every night from each of the outbreak sites. And that has really informed the development of this material to ensure that it is delivered to provide you with the best possible information to support your learning and your outbreak management planning. So when you open the document, you should have at the forefront of your mind the people that you're reading this document for. And you're reading it for the staff that you lead, for the partners in care that you have, the families and representatives of the consumers that you deliver care to, the consumers that you must protect. You're also reading it for yourself, to protect yourself and your family and the community that you live in. So there are a lot of stakeholders that are relying on you being very clear about how to manage outbreak planning. From our learnings, we have identified a number of key themes. And the first I want to talk about is visible leadership. It's really critical that you're able to demonstrate who is leading your service in an outbreak. You may find yourself with numbers of external agencies that are coming into your service, and they need to know who is leading, who is in charge. But all your stakeholders will need to know this as well. The second issue I want to talk about is role clarity. And when your service is under pressure and stress, it's really important that everybody understands their roles very clearly. Now, you may choose to assemble a management team to manage an outbreak that is different from the team that you would have in your business as usual environment. You may not usually have someone, say, in charge of hotel services, but hospitality staff will need direction in order to work safely during an outbreak as much as staff who work in your clinical services. So you need to ensure that you have assembled a team that is able to undertake the functions that are needed in an outbreak, and that people are very clear about their roles. Now, regardless of whether you're managing corporate services or you're managing clinical care, you also need to be competent in infection prevention and control. You need to manage yourself safely, and you need to be able to lead and manage others safely as well. Now, some of this can be tricky to identify yourself as the leader and to identify your team when you're all wearing PPE and your usual uniforms and name tags are obscured by that. But you will need to come up with a means of identifying yourself so that anybody coming through the door knows you are in charge, and these are the key people who are making the decisions at your service in relation to day-to-day management. The next issue I want to talk about is training, and many of you will use online training as your business as usual go-to. But online training is only the start of the journey. And for a critical process like PPE usage that requires 100% compliance, the sequence of donning and the sequence of doffing, staff need face-to-face training. They need repeated practice. They need feedback about the way they've put a mask on or the way they are working while they're wearing a mask. They need testing on a routine basis, and they need surveillance of practice. So understanding how to extend your business as usual training to develop the level of training and support and surveillance that is required for PPE usage. It's at another level. The staff that at the beginning of 2020 may have participated in an online training exercise around PPE may not even be your employees when the outbreak occurs. And for many services, staff that had trained earlier in the year either were not available or may have been furloughed. You will find yourself with staff that need face-to-face training and competence in PPE usage. And effective PPE usage means 100% compliance with it. You need to know your staff. You need to know their strengths, their needs, and their personal circumstances. It's really critical in planning a response to understand which of your staff will be the ones that will step up and those that will have to step back. And there's a number of reasons why staff have to step back. And sometimes it's their personal health circumstances or their family circumstances or their own fears and anxieties. But you need to know each person in your team and how they'll respond in an emergency. And so how are you going to know that you've got the right capability available in the event of an outbreak? Now, mock audits and simulations or trials or practical exercises, as Melanie mentioned, they're being used quite widely by aged care services to test their outbreak response. But these need to be realistic simulations. They need to, for example, simulate a 24-hour period so they cover all shifts, so that they can be a realistic test of how you are able to sustain an outbreak response over time. So, because what we learned was that some outbreaks can go for over 80 days. That's a long time to sustain an acute outbreak response. And for some services that find themselves in that circumstance for 80 days can then go on to find themselves with a second subsequent outbreak. So your outbreak response is going to be a real test of your key relationships. These are the relationships that you'll rely on and that need to be in place before the outbreak commences. Because once the outbreak has started, it's too late to date. So whether it's health services, GPs, nursing agencies, labour hire agencies, do you know the people that you need that will be required to support your outbreak response? And do those people know that you need them? So as we're coming up to the festive season, it probably wouldn't hurt to send some of these people a card just so that they know that where you are and that you're going to be contacting them potentially. Now, communication is key. It needs to be relevant. It needs to be specific to the person receiving the message, whether that be staff or families or consumers. Now, general communication is also important, but what you need to really focus on are the specific messages that you'll be delivering to individuals that are the messages that they need to receive. Now, you would know your consumers and your families and the families that will want key messages. For example, the family that wants to hear about their relative who, say, has insulin-dependent diabetes, and their interest is in making sure that their relative receives their meal on time so that they can also get their insulin. Now, that kind of messaging is critical because in an outbreak where there is heightened anxiety and fear, particularly when families are not able to have close face-to-face contact with their relative, they want to know what you're doing and that their person is safe and that their person is being cared for. So general messaging that delivers a progress report, always important, but the specific messages that staff need to allay their fears, that families need about their person, that that should be part of the suite of messaging that you provide. Thanks, I think.
Thanks, Anne. Okay, we've now time for questions. We've got about 20 minutes-ish or so to work through some questions, and we've had quite a few come in, which is fantastic. I'm going to start with one that came through early on, which was about whether an outbreak management plan is the same thing as the first 24 hours plan. Anne or Melanie, you might want to pick up on one of these?
I can pick on it really quickly, but the first 24 hours is really designed to be embedded within the outbreak management plan. It's one of the documents that would be accompanying it, and it really outlines in detail who needs to be notified and in what time frame, and to give you a very quick understanding of what happens in immediately, the first hour, etc. So it's one component, and it's certainly only designed to be picked up once you've actually got an outbreak.
Okay.
Nicola, I thought I'd just add that one service said to us, really an outbreak management plan is the first 24 days.
Right.
So it's the knowing that outbreaks can go for a considerable period of time. It's the plan that delivers a response over time that supports safe and effective care.
Okay.
It's also it's the action plan, whereas an outbreak management plan has to be much broader than that and identify your own people and who will do each of those actions, etc.
We've had a few questions about testing the plan and drills, and both Melanie and Anne have mentioned that. And so questions about how do we do this with other agencies? How do we do this across shifts? What are some of the things that we need to think about to make sure we really put it through its paces?
Well, we've had a couple of services talk to us about what they did, and one service invited people to a meeting and then just told them, okay, we're now in outbreak mode and we will now proceed to activate our plan. So they did theirs in an unannounced fashion. If you're going to be testing it with external services, clearly you will want to rehearse with them how you will want to do this, and you would need to seek their agreement, availability, etc. But that is that level of planning is very important, and those relationships obviously will support you in other instances other than in COVID outbreaks. So you should invest in those and actively seek to engage with those services. Now, they may also want to use your service as part of their own outbreak management planning, testing as well. So offer yourself as a partner to them.
I think there are two things that you can do. You can either do drills where you tell everyone, right, there's an outbreak and it's here, and you've really identified one scenario to test out and check that everyone knows what to do. But I think that the other thing you can do is look at each component and say what can go wrong here. You're obviously not going to drill if your index case is here, there 20 different places, but in your mind you need to be thinking, if the index case is here, what does that mean? So I think some of it is in the imagination and what can possibly go wrong, and some of it's in the physical drill.
And if I may, contingency planning is an absolute must. Your outbreak management planning preparation is not just reflecting on best and worst case, but this is our preferred way of dealing with that presentation. But if that doesn't work, or if that's not available to us, then we will do this other thing. Every part of your sequence has to have a backup plan because not every part of it will go as you fully expect. And I think Melanie made this point very well. So the planning process must imagine not a single scenario, but potential developments in a scenario which don't go in the way that you first expect.
And somebody's put through a question around that planning, and particularly making the point about surge workforce, which I guess comes to your point, Janet, around you don't know what's going to happen. You don't know what proportion of staff might need to be furloughed. You need to think about that as part of the planning process as well.
Yes, absolutely.
There are parts to that as well, because understanding that you don't know how many staff you're going to lose and that it may be significant, if you're taking that into account, your planning will seek to minimise the loss of staff by making sure that you don't have staff working across all areas, so that if all your staff are working across all your areas, then no matter where the outbreak is, they're all going to be furloughed. So just to try and get your staff working into pods and understanding where those pods are, so that if it's this staff member, you know that this staff pod has been close contact, but the others haven't. So it's think about it, I guess, with that sort of lens. How can you minimise the staff impact?
There are things you do know, though. You know that you'll be unpacking pallets of PPE. You know that you'll be potentially moving some consumers from their room to another room and moving some of their possessions and some furniture. So some of your planning can take into account what the activities will be and how they are best structured and managed, and who are the right people to do those activities. And some of the rehearsal and practice of that will make those things happen far more smoothly if they actually have to occur in the context of an outbreak.
Mm.
And don't forget to include consumers in your drilling and planning, because if they know what to do, that's going to be really helpful. And another example comes to mind of where a consumer learnt that they had the virus because they went outside their room and saw the notice on the door, which was a less than ideal way of letting them know that they were potentially going to become unwell. But in involving them, and the Commission's actually got a few resources to assist with preparing consumers, either at the beginning of an outbreak or if you think that you're at risk of having an outbreak, for consumers and their relatives, what to expect.
I'm going to change the nature of the questions a bit at the moment. What about for the bulk of facilities and services in Australia now, where there's actually quite low levels of community transmission? A lot of what we've learnt that went into this document came out of Victoria, which was intense, high levels of community transmission. But that's actually not the case for a lot of places, most places now, and hopefully won't be again, cross fingers. But what can services learn from this and apply? How do they apply this now in the circumstances that exist, fortunately for us, in most of Australia? What is it that we take from that? How do we apply it for where there's really low levels of community transmission?
I'll start and then hand over. As I said in my introductory comments, there are 3 sections in most of the chapters, and the first of those 3 sections is at all times. We did that very deliberately in the knowledge that there would be a time, which we've now reached, post-peak outbreak, where we are moving to a COVID normal way of operating. Now, we need to unpack what that means, not just for aged care, but indeed for our own lives and the way we go about our business, knowing that the pandemic is still very present and continues to be a risk to our normal way of life, let alone to the way in which aged care services are run. So my first response to your question, Nicola, is look to the section in the document within each chapter which is headed up at all times, because that is very deliberately targeting the circumstances in which we find ourselves now. Do either of you want to pick that up and take it further?
No, just that the at all times things really is going to be your best friend going forward as well, even not just within COVID, but really good knowledge within the service and crucially a culture and habitual good practice is going to prevent outbreaks that are not just COVID. And an understanding of everyone, that it's everyone's job to remind people when they see any of us doing something that we're not conscious that we're doing that we shouldn't be doing, and not feeling that you're overstepping the mark by reminding that, and that people understand that there's a potential for fatigue, that we all do it when there's community transmission, but then it just drops off and we forget because nothing happens, so we stop doing it, and that we must still pick each other up and not do that. And it's a bit more, well, it's a lot more in the health setting, in hospital settings, where the processes are much more embedded, and I think that's going to become the case in aged care as a result of this, because of the at all times IPC. It's the basics. Attention to the basics is absolutely the best thing. It's the basics are the basics because they work.
So your focus now will be managing the safe care of your consumers and managing safe work practices for your staff, and the safe engagement of visitors that come into your service and partners in care that are a critical part of the way care is delivered in your service, while always remaining vigilant that if the risk increases due to community transmission, that you have the agility to increase the protection that you provide through your effective outbreak management planning, because you're using this document that is a really critical resource to support you in these efforts.
Thanks. Some questions here about, okay, what does this mean? We're a small provider. We've only got, we're in the middle of nowhere. How are we supposed to do this? What do we do here? How do we apply this document that's 80 pages to our service? What help can there be to help us do that? Do we have to do it all?
So we encountered services that had, a household grouping of 8 that had an outbreak, and they were able to apply the same principles and practices and approaches to containing that outbreak and managing it. The document was developed with small services in mind and large services. So while there will be some parts of it that you won't scale up significantly because you're small, you still need to see your service and find your service in this document, and it's there for you to find. So if you start where I started with, thinking about your people, and use that as your reference to reading the document, you'll be able to find your way through the sections of the document and understand how to scale up or scale down depending on the size and the complexity of the service that you operate.
Yeah, not every little thing will be relevant to every service, and if that was the case, then everyone's outbreak management plans would be very similar. So what I would envision is that you have the document in one hand and your outbreak management plan in the other, and you check your own plan against the relevant sections, and just make sure that you've addressed all of the things that are in that where it's relevant to you.
That links to another couple of questions that have come through about checklists, asking whether we're going to be providing checklists, drawing on that.
So we would hope that you would develop your own checklists in response to your own understanding of what you need to do in an outbreak. So it's not going to be a whole checklist for the whole plan, but you might want to have a weekly checklist for have you got things updated. You will find things where you might want to check who's done what training and how recently, who you've had a conversation with about whether what their personal circumstances are, or do they feel confident that they know their role. So where checklists are relevant to you keeping up with your own planning, then that would be the sort of checklist. That the Commission won't be providing checklists because a one-size checklist is not going to fit all.
However, the design of the guidance really supports you developing a checklist. So you can work your way through this document, and we have colour-coded and arranged the material to support your own self-assessment and checklists. So it's a very accessible document for you to develop a checklist to suit your circumstances.
And what about home care? We've had a few questions that have come through about home care. The document is targeted at residential aged care, but are there things in this that home care providers can also take and use and learn from?
Look, I think so, and we certainly encountered outbreaks, small single staff or a couple of staff working in the home care space during the Victorian outbreaks, and the information management in relation to home care staff and where they're deployed and the protections and safe work practices that are built around the schedule of work that is provided to them, as well as the information that's provided to the consumers of those home care services, is really critical. So that is probably more of the focus in the home care space. Melanie, did you want to add to that?
Not really, but home care is very diverse, and if clinical care is being provided by home care providers, then more of the components of the guidance will be relevant. And so such things as identifying particular risks, identifying who's responsible for overseeing that, who's responsible for overseeing PPE ordering, that the usage is maintained, that people are trained in a way that's both theoretical and practical. If various people are missing, what are the crucial things to keep going and who's going to take their roles? All of those things apply to home care just as much as they do to residential aged care.
We've just got time for a couple more questions and then we'll wrap. I'm just thinking about if we've got people who are just starting out looking at this. I mean, hopefully that's not the case, but if you want to kind of, what are the first couple of things that actually you really need to nail this to have a good, solid starting point for moving forward about your outbreak management planning? What are the kind of top 3 or 5 things that this is what you really need to nail?
Let me start. What we're looking for is for services to understand risk. And that's not a novel idea. That infuses the approach we take to assessing against the standards as well. If an aged care provider of residential services understands risk in that particular setting with that group of consumers in that built infrastructure and that local environment, then you're well on the way to understanding what you need to do to plan, to prevent and prepare for and respond and recover from a COVID-19 outbreak. You want to pick it up from there?
You need to know your people. You need to know your consumers, their information, the rooms that they live in, their relatives and their current contact details, email and mobile phones and relationship. You need to know how you're going to recognise and deliver care to people once they've moved into different rooms. How are you going to identify them? And it was the case that services started to use risk identification bands as an ID marker. You need to have your know your staff as well as their strengths. You need to have their contact details. This all sounds really basic and really fundamental, but it's the basis to start working with people, and that is having the data set that you need. And in the event that you are not available to lead that outbreak, that someone else can pick that information up, and maybe an external service is actually going to need that information and they will be able to use it. So starting with the information that is critical to any emergency or disaster is actually the basis to start working with an outbreak.
If you are either writing or hopefully reviewing your outbreak management plan, it absolutely needs to be done by somebody with intimate on-the-ground knowledge of your individual service. So that encompasses all that Anne said. So somebody who actually knows whether what you're putting in your plan is going to work for your current set of staff and your current set of residents and your current set of visitors and all the other people that come into your service. So it's got to be done absolutely making it fit for purpose for your service, and it has to be done by someone with intimate current knowledge.
Thank you very much. Just before I hand back to Janet to close, I've had a question about getting access to the document because there is so much out there at the moment. It's on the Commission's website, and I think it was forwarded through a mail out from the Commission and from the Department of Health as well. So if you have a look at for search outbreak management planning for the Commission, you will come across it, and the link, as I said before, to the website will be there. So I'll hand back to Janet to close the webinar.
Thank you, Nicola. And thank you all for staying with us and spending the hour with us, and obviously for your participation through the questions. I wonder how you're feeling about it. Are you satisfied? Are you reassured? Are you boosted in confidence, or are you nervous and a bit more anxious? Wherever you find yourself, what I really want to leave you with is a request that you spend just a couple of minutes, if you have that time at the end of this webinar, deciding what you're going to do next with this resource. Are you going to read it more thoroughly? Are you going to share it with key staff and then ask them to study it before you meet with them to talk about it? Are you going to convene a planning workshop? Or are you going to ask a responsible staff member to do as Melanie suggests and to put your outbreak management plan against the guidance and to see how it measures up? You might do all of those. I hope you do at least one of them, because that really has been the point of this afternoon. What I'm looking for is that you at least have a better understanding of the responsibility you carry as an approved provider for protecting the safety and well-being of residents in your care, and how the guidance might assist you in doing that in the context of the pandemic. Now, ignorance is not a defence. You must be alert and on guard and ready. And I'll go back to the schema I used in my opening comments. Plan, do, check, act. Or in this particular context, plan, set in place the provisions, check and drill those provisions, and then take action to adjust or improve and repeat the cycle. Keep doing that and you will be well prepared. You may well prevent an outbreak, and you will certainly be better placed to respond decisively and promptly if there is, and let's hope there's not, but if there is an outbreak in your service. Don't do it because the regulator's asking you to do it. Do it because older Australians deserve it from you and from us as part of the aged care sector. Now, I'd like to close by sharing with you a video that we've produced. It's a resource developed to complement the outbreak planning guidance. We'll play it now. It will be available also online from the Commission website, and you may want to use it to share with your colleagues to introduce them to the resource that we've been talking about in the last hour. Thanks everyone for your time and for your attention.
COVID-19 can be more serious for some older people or people with medical conditions. To protect people in aged care, residential aged care facilities are directly responsible for putting in place measures to prevent the introduction of COVID-19 to their service, and to monitor that these measures remain in place and are being adhered to at all times. As providers of aged care, you must also do everything in your power now to ensure your service is able to immediately respond following a confirmed or suspected case of COVID-19, and to minimise the impact should an outbreak occur. Your outbreak management plan should be tailored to your service and clearly identify who is responsible for relevant tasks in the event of an outbreak. This means that the roles and responsibilities of all relevant staff must be clearly identified and documented. Key staff contact details should be kept up to date. Your plan should be communicated to your staff, consumers, and their representatives. To ensure everyone knows what to do in the event of an outbreak, test your plan through the use of drills and scenario testing. As part of your planning, review your infection prevention and control guidance and ensure that all staff are trained. Staff should be encouraged to remind and support each other in understanding and recognising the critical importance of infection control. You should regularly review your plan and ensure it is consistent with any local, state or territory and national updates about COVID-19. This will allow you to ensure your plan is responsive to the changing environment and assist you to understand and communicate what is required. Your outbreak management plan should include information about how your service intends to deliver care and services to consumers during an outbreak. Think through every detail so you can ensure that your staff have confidence in what they need to do and that the people in your care continue to be well looked after. Consider the worst-case scenario and think about what you will need to do if some or all of your staff have to be furloughed immediately. The Commission's Outbreak Management Guidance will support you to plan, reduce the risk of, and prepare for a COVID-19 outbreak in your residential care service. The guidance includes practical, action-oriented advice and tips which will help you understand the relevant considerations in preparing for an outbreak. To ensure your service is prepared to respond in the event of an outbreak, the best thing you can do is start putting plans and actions in place now. The individuals receiving care at your service, your staff, health professionals, service providers, and other community organisations are key to your preparation and response. Involving these key partners in the development, testing, and review of your planning will help to optimise your preparation and ensure the best outcomes for all. For more information, visit agedcarequality.gov.au.